Hi, and welcome to our next Neonates in a Nutshell presentation. This is the first of a surgical theme with more to follow. Although working on a non-surgical unit, we are rarely presented with some of these conditions as they are usually planned and delivered in a specialist centre. We do get the occasional unexpected delivery or babies returning to us post-surgery. So to have an idea of the management and what to expect is helpful. And also, if you work on the transport team, we often get to go and pick these babies up, transfer them to a surgical centre. So this presentation is going to focus on Exomphalos. So as you can see from the photos, the abdominal wall contents are outside the body, but unlike gastroschisis, which I will cover in another session, in this occasion, they are covered by a sac and the umbilical cord is attached. So the incidence of an exomphalos is about 1 in every 10,000 births. So looking at the pictures, we've got two examples here. Firstly, on the left, this is an exomphalos minor, and this contains just a small proportion of the intestine, and the second photo on the right contains more intestine and the liver additionally. So the associations with exomphalos, there's often a chromosomal or heart defects, and many fetuses will die unfortunately before birth. Another important associated syndrome is Beckwith-Wiedemann. These are usually large babies, and symptoms may include hypoglycemia, macroglossia, which is a large tongue, large abdominal organs, and then they can sometimes have creases or pits in the skin near the ears, and also some kidney abnormalities. As these babies grow up, they also have an increased risk of tumours, particularly a rare form of kidney cancer called Wilms tumour, or a cancer of the muscle tissue, or liver cancer, hepatoblastoma. So you can see here for preparation and planning that a detailed scan is necessary, and then parents are offered chromosomal studies, which can help guide the carer for the parents and with their decisions for the future. So many parents do make a difficult decision to terminate pregnancies where the baby has an exomphalos if it's associated with other anomalies. However, a baby with just an isolated exomphalos do generally have a good prognosis. So a plan will be made following delivery under the guidance of the surgeons, and emergency surgical attention is rarely needed immediately after birth. However, there is a spectrum. So the small defects, an early operation may be indicated, and large defects, sometimes conservative management is appropriate, or they can have special dressings with later surgery. If the membrane was to rupture, then this is and would require urgent surgical attention, and we would need to really keep a close eye on the colour and perfusion of the gut, treat it a bit more like a gastroschisis. We would need to wrap it in cling film and keep it central so that the blood vessels aren't kinked, and which can affect the perfusion. And as I already said before, generally if there's no other anomalies, then the outcome is good. So other complications, these babies often obviously are not feeding, so therefore require parental nutrition. So this can occasionally cause complications such as line infections and liver dysfunction. These babies can also They also grow slower and before birth, and therefore maybe IUGR or can be premature, so with the complications associated with that. They often have multiple defects, heart defects. They can also have underdeveloped lungs. This is because the abdominal organs usually provide a framework for chest growth. So when those organs are misplaced, the chest wall doesn't grow properly, providing a smaller than normal spaces for the lungs to develop. And therefore, babies can often need some respiratory support, supplementary oxygen for a while. Some infants also may have GI problems, including reflux. So, how should these babies be delivered? What is the safest method, do you think? So, usually a normal vaginal delivery is fine and safe. However, if it's a large exomphalus with the liver in the sac, it's usually safer to deliver by caesarean section. In all other cases, with any other indications or other anomalies, a C-section is only indicated, as in all other babies. So, on the NICU. So when the baby arrives on the NICU, we need to do our initially our usual care, so making sure the baby stays nice and warm. Once in the incubator, we can give the baby a thorough top to toe examination, looking for these other anomalies and support them as appropriate. For obvious reasons, we need to nurse the baby supine. We can't put them prone onto the anomaly with risk of pressure and rupture. They will need a cannula for fluids. They may need some boluses depending on their condition, but otherwise maintenance fluids and a nice strict fluid balance. We'll give them some prophylactic antibiotics to prevent infection. They can have vitamin K as normal. We need to insert an 8 franc NG tube, aspirate and put this on free drainage and replace any losses. And then we need to monitor blood sugar levels, and additionally we can take photographs, and then we need to liaise with the paediatric surgeons and organise transfer. So management. So most of these babies are relatively well at birth unless they do have a cardiac anomaly or breathing problems. As I've already mentioned, we need to monitor the babies with Beckwith-Wiedemann syndrome for blood sugars, but most babies with a small or medium-sized exomphalus, once they've been transferred, can often be closed in a single operation. Sometimes the skin and not necessarily the muscles may be closed over the exomphalus, and then maybe they need surgery again later to close the muscles. Reduction of the liver must be done slowly, as the venous drainage from the liver can easily be kinked during this process. So, if the skin can't be closed over a large exomphalus, then there are alternatives. A silastic pouch can be used to allow progressive reduction of the bowel over a number of days before closure. Or sometimes we can manage without surgery, and there's various dressings while the skin grows slowly over the sac, or alternatives like like medical grade honey dressings or Vaseline. So this next slide just shows the progression of the exomphalus over the days from day 3, and then they've applied a dressing over the top and then supported it here so to allow slow reduction. This shows the exomphalus, so further on, so at 7 weeks, you can see the skin is starting to grow up the side and of the exomphalus, and by 9 weeks it's sort of reaching halfway. And then at 12 weeks, you can see here that they've managed to have complete reduction of the liver and bowel. And then lastly, there's a picture of a young child, and you can still just about see the defect on the abdominal wall. So the key learning points. An exomphalos is a condition where the intestine is prolapsed through an abdominal wall defect at the umbilicus. It can be a small exomphalos minor with just the intestine alone, or an exomphalos major, which may contain the intestines and liver. The sac is covered with peritoneum, Wharton's jelly, and amnion. Then antenatal diagnosis and consideration of other anomalies is good, and it's really important these parents get counselling. Possibly surgery to treat, but this is rarely an emergency. And the management aims is to close the skin and the muscles. And lastly, the survival rates are 30 to 70%, so this depends on the seriousness of the other anomalies. Okay, so I hope you enjoyed the presentation. This gastroschisis will follow in the next week or so. Any comments or questions, please email or grab us on the unit, and we'll be happy to try and help. Okay, thanks. Bye.